A very good evening, everyone. After elaborative sessions so far, finally move on to final talk of the day. So my topic for the final session is anticoagulant during renal replacement therapy. So what are the modalities of renal replacement therapy commonly encountered in the clinical practice? Are intermittent hemodialysis, slow efficiency dialysis, or continuous renal replacement therapy. These are techniques where the anticoagulant is used, but other form of renal replacement therapy is the peritoneal dialysis. It doesn't require any anticoagulation. So not only for renal replacement therapy, any form of extracorporeal therapy will require an anticoagulation supplementation. If you see the intermittent hemodialysis or low efficiency dialysis are of short treatment duration, and the blood flow rate usually in this technique is high. So these techniques can be done most of the time without any anticoagulant, especially in terms of hemodialysis of 2 hours, 3 hour sessions can be done without any anticoagulation. But in case of CRRT, where you need to continue the technique for 24 hours or for prolonged duration, there is indeliberate activation of a clotting pathway. So this anticoagulation becomes mandatory in CRRT technique, or in case SLED, which is done for a longer duration. So why the coagulation system gets activated in the renal replacement therapy? Because here the blood is flowing through an extracorporeal circuit. So the blood, as you know, when it comes in contact with any foreign material, it has tendency to clot. So here there is a circuit outside the body. So as the blood flows through this circuit, the clotting system gets activated by contact mechanism. So there is activation of intrinsic pathway. Over the time period, the extrinsic pathway will also get activated. And not only that, if you see all the critically ill patients are in a procoagulant state. It is due to inflammation and also due to sepsis. Both of these are procoagulant state. So these patients have the tendency to form a clot. In addition, the turbulent flow, when you're dialyzing because of a smaller catheter or a catheter thinking, there can be a turbulent flow. So this can activate the clotting pathway. So all this can lead to clotting in the circuit or in the filter. So what happens if there is a clot in the circuit? Why we are worried? Because it reduces the lifespan of the filter. So once the clot forms in the circuit or in the filter, the efficiency of the filter over the duration decreases. So thereby the solute clearance is affected. As clot is formed, the lifespan, the duration for which the dialysis can be done also will decrease. So that dose and also the duration of the dialysis gets affected. So what happens is the studies have shown that the CRRT ideally, when it is scheduled for 24 hours, most of the time because of the clotting issues, on an average, the CRRT technique has to the schedule ideally for 24 hours has to cut down to 16 hours due to clotting issues. In all cases, we have in order for a renal replacement therapy to get continued, you need to replace the circuit again and the filter. So this all has to cost to the patient. Not only that, a filter clotting can lead to a blood loss of approximately 200 ml. So in order to reduce this filter clotting and improve the efficiency and lifespan of the filter, you need to give an anticoagulant. So there are the various anticoagulants available, both systemic and the regional anticoagulants. An ideal anticoagulant should have optimal antithrombotic activity with a low bleeding risk. And whatever the anticoagulant you are giving, it has some of this concept drug may enter into systemic circulation. So an ideal anticoagulant should have minimal systemic effects, and it should be of short half-life, and it should have easy antidote availability, so that in case of any adverse bleeding event, we can reverse this using an antidote. So if you see in this slide, there are various anticoagulant options available for the renal replacement therapy or in case any extracorporeal technique. Those on the left side are mainly systemic anticoagulant techniques, and those on the right are regional anticoagulant. Among the systemic anticoagulant options, we have unfractioned heparin, low molecular weight heparin, citrate, a prostacyclin, or a direct thrombin inhibitor like pyridine or gatrobin, or serine protease inhibitors like nafamostat. Among the regional anticoagulant techniques, it is a combination of heparin protamine or a regional citrate anticoagulation with administration of calcium. So what is the difference between systemic and regional anticoagulation is? In regional anticoagulation, the anticoagulant effect is confined only to the circuit and with less or negligible systemic effects. Whereas in systemic technique, you are administering the drug systemically so that the anticoagulant effect is seen in the circuit and also in the patient. So coming to fraction heparin, it is the most commonly used drug and most widely available. How it prevents the clotting is by activation of antithrombin 3, which in turn inhibits the factor 10A and 2A. So unfractioned heparin is an indirect inhibitor of factor 10A, which acts by activation of antithrombin 3. So it has a half-life of 90 minutes, but in case of renal failure, the half-life is prolonged 3 hours. So for anticoagulant effect, the various dose available are for priming, you need to instill 5,000 to 10,000 units to 1 liter of normal saline. And before anticoagulant, you need to give a bolus of 1,000 to 5,000 units, followed by infusion of 5 to 20 units per kg per hour. This infusion should be in the arterial site of the circuit. And while giving heparin, you need to monitor coagulation because you need to adjust the dose based on that. So for that, you need to monitor APDT, and the target should be 1.5 to 2 times normal. In other case, this APDT requires a lab help. So other thing you can do to monitor the coagulation is bedside ACT mounting for heparin action. And as I said, this heparin has got an antidote, which is PROTAMINE. So what are the advantages with the use of heparin is it is readily available, and also the cost of heparin is less compared to other anticoagulant options. And the half-life is shorter. As I said, it is 90 minutes and it has antidote for reversing the coagulation. But the disadvantage is that heparin has got unpredictable pharmacokinetics. The anticoagulant effect with the same dose of heparin differs from patient to patient. Not only that, it can also cause problem with heparin is that there can be heparin resistance or heparin-induced thrombocytopenia. So what is heparin resistance? It is a term used when you need to administer more than 35 units of heparin per day to achieve APDT of 1.5 to 2. So if you are requiring more than 35,000 units, then you can coin the term heparin resistance. So what is the most common cause for heparin resistance is antithrombin 3 deficiency. So cause for antithrombin 3 deficiency can be inherited, which is very rare, but most of the case it is acquired due to perioperative bleeding, cirrhosis. Hemodialysis itself can cause antithrombin 3 deficiency leading to heparin resistance and shock. So heparin resistance, the most common cause is antithrombin 3 deficiency. The second cause for heparin resistance is elevated factor VIII levels, which you see in cardiac surgical patients. So another technique where you can achieve anticoagulation is regional anticoagulation using heparin protamine combination. In this case, you need to infuse heparin into the arterial line of the circuit. That is pre-filter, you are administering the heparin. So thereby the heparin acts within the circuit, reduce the filter clotting. And post-filter, you are administering the protamine to counteract the heparin. So that the anticoagulant effect is lost in the post-filter phase, so that the anticoagulant effects are minimal or less within the patient. You are by using this heparin protamine combination, you are trying to achieve the anticoagulant only in the circuit. So when you are using this combination, you need to monitor APTT in the circuit and systemic circulation. But the problem here is the half-lives of heparin and protamine differ significantly. The half-life of heparin is 90 minutes, whereas protamine is approximately 5 minutes. So once whatever the leftover drug in the post-filter phase, it enters into the circulation, they will get dislodged. So the protamine, because the half-life is very less, it will metabolized faster than the heparin. In that case, the heparin effect can be prolonged. So in this case, you may need to re-administer or second dose of protamine is required. Not only that, protamine has got systemic effects like it causes histamine release leading to vasodilation and hypotension, potentiate the inflammatory mediators. It can cause pulmonary hypertension and right heart failure. So coming to low molecular weight heparin. So just like this mechanism of action is similar to heparin, but if you compare with heparin, it has got a better pharmacokinetic profile, but it is expensive and it has got a longer half-life than the heparin. Not only that, in case of renal failure, it will get accumulated, especially when the creatinine clearance is less than 30 ml per minute. You need to reduce the dose of the low molecular weight heparin by 50%. And unlike heparin, where you need to monitor APTT or ACT for monitoring the coagulation, for low molecular weight heparin, you need to monitor factor 10A levels. So initial studies show that with the use of low molecular heparin, the bleeding chances are high when used as anticoagulant during RRT. But if you titrate the low molecular weight heparin according to anti-10A assay and compare with heparin, there is no difference in the bleeding. But unlike heparin, the low molecular weight heparin is not commonly used for anticoagulation during RRT. Coming to another form of technique, that is citrate anticoagulation. It is usually available as a trisodium salt. So citrate has got not only anticoagulant action, but it also acts as buffer, and also it has got anti-inflammatory action. How it acts as buffer is citrate, once it enters into systemic circulation, metabolized in the liver to release the bicarbonate. This bicarbonate can neutralize, and because it's an alkali, it can tend to reverse the acidosis in renal failure patient. So how it works as an anticoagulation? How citrate works as anticoagulation because of calcium chelation. As you all know, the calcium is the most important mediator, also coenzyme for many enzymes in the coagulation pathway. So by combining with the calcium, it is causing calcium chelation, thereby preventing the clotting in the body. So the citrate has got a plasma half-life of 5 minutes, and the molecular weight of the citrate is low, that is 300 Daltons. Because of this, it can be partially removed as a calcium citrate by convection or diffusion during the renal replacement. So approximately about 50% of the citrate calcium complex can be lost during the renal replacement therapy. As I said, citrate is metabolized in the liver to form bicarbonate. Other organs where the citrate can metabolize is the skeletal muscle and the kidney, but predominantly it is the liver where the citrate is metabolized. If you see this, the circuit diagram, as the blood flows as the blood is drawn from the patient through the pump at the rate of 100 to 2 ml per minute, the blood is driven to the filter. And see, before the pump, there is citrate solution added to the circuit. That is pre-filter phase. So the amount of citrate delivered to the filter depends upon the blood flow rate, citrate concentration, and the citrate dose. So here the citrate gets added to the circuit. What happens here? The citrate binds with the calcium within the blood and chelates it. So thereby the clotting is prevented. So the amount of blood entering into the filter is devoid of the calcium, so that the clotting mechanism is affected. So in order to achieve this, the citrate dose within the circuit should be 3 to 4 millimoles per liter. At the same time, the ionized calcium should be 0.25 to 0.4 millimoles per liter within the circuit to achieve anticoagulation. And during this technique, and you can see whether the technique is CVV-HD or CVV-HDF, there can be a loss of citrate calcium complex, about 40 to 60% depending upon the dose. The remaining citrate calcium complex enters into the circulation, to the venous line, it enters into the body, and the citrate gets metabolized. And also, because most of the calcium is created by citrate, there can be hypocalcium in the circulation. So you need to administer calcium into the circulation before it enters into the patient. This you can give in the post-filter phase, or you can give separately through a separate line using the central line. So calcium infusion can be given. And one more important thing is that when in case of citrate anticoagulation technique, you need to monitor the ionized calcium in the pre-filter phase, that is the systemic circulation, and the post-filter phase. So you need to achieve the target of ionized calcium 1.1 to 1.25 within the systemic circulation to prevent hypercalcemia, whereas within the circuit, it should be 0.25 to 0.4 millimoles per liter. And when the technique is CVV-HD, you know there will be a dialysate solution. So in CVV-HD technique with the citrate anticoagulant, the dialysate should be free of calcium. Whereas in case of CVV-HDF, in addition to calcium-free dialysate, you are using a replacement fluid here. So it can be a pre-filter or post-filter. When you are using a pre-filter replacement solution, the citrate solution itself can act as a pre-filter replacement fluid. Whereas the post-filter replacement, just like a dialysate solution, should be free of calcium. As I said, you need to monitor the ionized calcium, both in the systemic circulation and in the circuit. In order to achieve optimal anticoagulation, the ionized calcium should be 0.25 to 0.4 millimoles per liter within the circuit. And to prevent hypocalcemia, you need to administer calcium separately through central line or peripheral line, but central line preferred because the calcium can cause phlebitis. So what are the various preparations available, citrate solutions available? It can be a commercial or a custom-made preparation. And predominantly it is two types, either isotonic citrate solutions or a hypertonic citrate solution. The isotonic citrate solution has got two functions. It not only works as an anticoagulant, but it can work as a replacement fluid also. Examples include prismocitrate 10/2, prismocitrate 18/0, or CitraHF. Usually available in 5 liters bag preparation. Whereas hypertonic solutions differ from isotonic in that they have got high sodium content, which makes it hypertonic. So there is a risk of hypernatremia when you are using this hypertonic high sodium content citrate solution. So in order to avoid this, when you are using hypertonic citrate solution, the replacement fluid or the dialysate should be hyponatremic with low or nil bicarbonate solution. So examples of hypertonic citrate solutions include acid citrate dextrose solutions or trisodium citrate 4% concentration. And these hypertonic solutions are usually available in 500 ml or 1000 ml bags. So if you see this table, you can see the various preparations. On the left side, there are hypertonic citrate preparation. On the right is the isotonic preparation. And if you see the sodium content in hypertonic preparations, it is 224 or 408 millimoles, whereas in isotonic preparations, it is 136 to 140 range. And the volume of the solution usually hypotonic is 500, 1000 or 1500 ml bag, whereas isotonic preparations are available in 5 liters bag. And when you are using this hypertonic solution, some of the preparations are commercially available. For example, this citrate calcium dialysate K2 preparation. This is the dialysate preparation commercially available. So it is available as K2 or K4 preparation. Only difference is K2 means the potassium concentration is 2 millimoles, whereas K4 means potassium concentration 4 millimoles. Similarly, there are commercially available replacement solutions also. Examples like Prismasol and Foxalium. And if you see, as I said, the hypertonic, when you are using hypertonic citrate solutions, the replacement or the dialysate should be low sodium content. So if you see in this K2 preparation, the sodium content is 133. Here the dialysate sodium is 133. Whereas in case of isotonic preparation, the dialysate sodium content is 140 millimoles. So coming to the complications with the citrate anticoagulation, the first one is the metabolic alkalosis. So why the metabolic alkalosis occurs? Because of imbalance between the citrate infusion and the citrate removal. So when the citrate infusion is high or a citrate removal during the technique dialysis or hemofiltration, removal is low, this can lead to citrate accumulation or citrate concentration increases. So this can lead to metabolic alkalosis. Because more the citrate is delivered to the liver, there is increased generation of bicarbonate causing the alkalosis. Not only that, inadequate matching of the regional citrate solution, because there are various preparations available. So the citrate concentration, bicarbonate concentration is not properly matched, that can lead to metabolic alkalosis also. So in order to avoid this, or when there is metabolic alkalosis, how to manage is reduce the alkali or increase the alkali loss. So this can be achieved by reduce the citrate infusion rate. So how to reduce the citrate infusion rate? So reduce the blood flow or reduce the target citrate dose by delivering high ionized calcium. Not only that, increase the citrate or bicarbonate loss by increasing the dialysate or replacement fluid rate. Now, the third option is you can reduce the bicarbonate concentration in the dialysate or replacement fluid preparation so that the bicarbonate concentration reduces. And not only that, when there is a metabolic alkalosis, make sure that you are not administering any exogenous buffer. For example, the more blood preparations can contain citrate and anticoagulant. So when you are giving a blood product, that citrate can get accumulated and leads to alkalosis. And some of the TPM preparations contain acetate, which is also an alkali. So you need to consider this when there is metabolic alkalosis. The second complication is the metabolic acidosis. It is due to imbalance between the citrate bicarbonate administered and removed. So in such cases, how to manage? Increase the citrate infusion, because there is acidosis. Then you can correct this by increasing the citrate infusion. At the same time, reduce the citrate or bicarbonate loss by decreasing the dialysate or replacement fluid flow rate. Or you can administer exogenous bicarbonate infusion, where you can give separate infusion, not only in the circuit, but the systemic administration of bicarbonate. So not only that, the metabolic acidosis can also occur because of inadequate citrate metabolism, because the most common organ where the citrate gets metabolized is liver. So in case of liver failure, the citrate is not metabolized, so that the bicarbonate is not generated. This leads to citrate accumulation and causing metabolic acidosis. So in such cases, you have to reduce or stop the citrate infusion, increase the citrate loss by increasing the dialysate and replacement fluid rate. At the same time, you can give exogenous alkali, that is bicarbonate infusion. The citrate metabolism can also get affected in septic shock, cardiogenic shock, or a low perfusion state because the bicarbonate generation is affected in this patient. So what happens in the case of citrate toxicity, or how it can be identified, is, as you know, as I said, the citrate toxicity is not seen routinely. Only in case of liver failure, this complication is seen. So how to identify this is, you can see because of the citrate accumulation, there can be metabolic acidosis, there is increasing in the anion gap, or hypocalcemia, because whatever the citrate is accumulated, it chelates the calcium, so it leads to hypocalcemia, that is ionized hypercalcemia. So in order to identify this, you need to check both total calcium and also the ionized calcium. So when the ratio of total calcium to ionized calcium is more than 2.5, you can suspect the citrate toxicity. But the studies have shown that if you take a cutoff of 2.1, then you can identify the citrate toxicity very early with a sensitivity of 89% and specificity of 100%. So in case of citrate toxicity, you need to reduce the blood flow rate, stop the citrate infusion, and also exogenous administration of citrate should also be stopped. So what about the, so because there is a problem of citrate toxicity in liver failure, can you use the citrate in liver failure? The answer is yes, can be used, but only in mild to moderate cases. So how to identify which patients we can use and which patients to avoid? So when the prothrombin time is more than or equal to 33 seconds and the lactate is more than 3.4 millimoles per liter or a bilirubin more than 7, these are the predictors where you can identify that these patients will more likely develop a citrate toxicity if you administer in liver failure. So in this patient, it's better to avoid citrate as anticoagulation. Otherwise, you can use in mild cases. The other complication is hypocalcemia. So in order to identify, you need to monitor ionized calcium both in the systemic circulation and the post filter. So as soon as you initiate the citrate anticoagulation, within 1 hour, you check this ionized calcium. Later, it should be followed every 6th hourly or 8th hourly. Whereas the total calcium should be checked every 12th hourly or at least once daily. Your target is to maintain the systemic ionized calcium within 1.12 to 1.2 range. But in case of rhabdomyolysis, where you are initiating an RRT for AKI, and if you are using a citrate as anticoagulation, your target should be slightly on the lower side, like 0.9 to 1.1, because there can be rebound hypercalcemia in rhabdomyolysis. And you know, if hypercalcemia is uncorrected, it can lead to parathyroid activation, which can increase the osteoclast activity, leading to bone resorption fractures. So this is about hypercalcemia. Not only that, there can be hypercalcemia and hypomagnesemia also, because the citrate not only chelates calcium, it can also chelate magnesium also. But most of the replacement or dialysate solutions contain some of the magnesium. So this hypomagnesemia is not seen commonly. And another complication, hypernatremia, which you encounter by using the hypertonic citrate solutions. So the advantages with the use of citrate anticoagulation is you can achieve anticoagulation within the circuit, thereby avoiding the systemic effects. And if you compare with heparin, the anticoagulant effect of citrate is superior, and also it has the filter lifespan is more with a citrate compared to heparin, and the activation of leukocyte or the inflammation is less with citrate than heparin. And we all know that the risk of bleeding with the systemic anticoagulant 30%. So by use of citrate anticoagulation, the chance of bleeding is very less. So it is safe to use in patients who are at risk of bleeding or a recent bleeding, who are actively bleeding also. So as you are avoiding heparin, there is no problem of heparin-induced thrombocytopenia. Another advantage is that it acts as a buffer because of the bicarbonate generation. And the last advantage is that citrate itself can act as an energy substrate. One citrate molecule can, the oral citrate can provide 150 to 280 kilocalories per 24 hours, whereas the citrate dextrose combination can provide up to 600 kilocalories, whereas lactate buffer solutions can provide up to 600 kilocalories for 24 hours period. So there are various citrate protocols available, how much dose should be administered at what rate, and how much should be the calcium infusion rate. These various protocols are differ from the hospital to hospital and country to country. So, but not all citrate protocols are effective. Each hospital has their own protocol. But one approach is like how to achieve this anticoagulation with a separate infusion of the 4% citrate solution. So the amount of citrate delivered into a circuit determines the blood flow. So by controlling the blood flow and the dialysate flow and achieving the optimal ratio of this blood to dialysate flow, you need to control this acid-base disturbances. So for suppose if there is alkalosis, you need to reduce the blood flow so that the amount of citrate delivered will be decreased. So by changing the 20% blood flow to dialysis flow, you can yield a bicarbonate difference of 4 millimoles per liter. So these are the various examples for the citrate anticoagulation protocols. And there are various protocols available with the use of hypertonic solution and also isotonic solution with post-dilution and pre-dilution technique, and also protocols for SLED. But it is usually time taking, so we can't discuss all this in detail. So that is about the citrate anticoagulation. Coming to other form of anticoagulation is the direct thrombin inhibitors. Usually the heparin or citrate, which is commonly used for anticoagulation during RRT, this direct thrombin inhibitors comes into role in case of heparin-induced thrombocytopenia, or when you can't use a citrate in case of CRRT technique. So among the direct thrombin inhibitors, it is argatroban or recombinant hyaluron represents are available. So argatroban provides anticoagulation by directly inhibiting the thrombin. It has a half-life of 45 minutes and it is metabolized in the liver and secreted in the bile. The molecular weight is 500 Dalton. Coming to hyaluron is slightly higher molecular weight than argatroban. It is 6900. And unlike argatroban, it is excreted via kidney. So the half-life can be prolonged from 1 to 2 hours to 50 hours in renal insufficiency. So for this direct thrombin inhibitor, the monitoring of coagulation is by occurring clotting time. So another anticoagulant is bivalirudin. It can be given as infusion in case of heparin-induced thrombocytopenia for achieving the anticoagulant. It has got a short half-life and also the clearance is by extrarenal and extrahepatic mechanism. Coming to heparinoids, it's nothing but example is the danaparate, which is derived from the pig intestinal mucosa. It acts by inhibiting the factor 10A. To some extent, it also inhibits the factor 2A also. Though used in heparin-induced thrombocytopenia, these heparinoids have a cross-reactivity with heparin PF4 complex, so use with caution in heat. And the half-life is prolonged to 36 to 48 hours in renal failure that doesn't have any antidote. And another anticoagulation that is a direct factor 10 inhibitor is the fondaparinux. Here, when you are using fondaparinux, there is no need to administer any loading dose. You can administer a daily dose of 2.5 mg per day for achieving the anticoagulation. And when you are using fondaparinux, you need to monitor anti-10A levels, and the target is to keep 10A within 0.25 to 0.35 international units per ml. So whatever with anticoagulant, there is chance of bleeding risk. But what are the options available in case of a patient who is coagulopathic, like thrombocytopenia with a platelet less than 50,000, with INR is more than 2 or APT is more than 60 seconds, or who is actively bleeding or had an event in the last 24 hours. With use of anticoagulant, there is a chance that the patient may have significant systemic bleeding. So in this patient, you can try to run a circuit by avoiding anticoagulation. Now, so what are the options available? Is you can prime the circuit with a saline or a heparin, and there is no need to administer heparin as intermittent bolus, but you need to administer saline flushes intermittently in order to prevent the clot formation. But the disadvantage is, as you are using saline for intermittent flushing, there can be fluid overload, or you cannot achieve negative balance by using this technique. So what are the other non-coagulant anticoagulant measures to prevent clotting is venous access. As I said previously, a turbulent flow can promote a clotting within the circuit. So in order to avoid this turbulent flow, you need to use a wide bore cannula, usually double lumen cannulas, and it is better to cannulate jugular vein, especially on the right side, or femoral vein, because this jugular vein on the right side or femoral has got a straight course, there is no tortuous or angled course. So the turbulent flow is less in this veins, and it's better to avoid subclavian vein for venous access because the subclavian has got an angular course. Thus, the flow can be turbulent or the catheter can get kinked in this case, so that flow becomes disturbed and promotes clotting. And make sure that when you are using femoral catheter, preferably is 30 centimeter length or at minimum 20 to 24 centimeters should be the length, and jugular catheter tip should be in the right atrium to achieve a good flow. And also any catheter malfunction should be addressed immediately to prevent the clotting in the circuit. And also the venous air trap, the blood level in this trap should be higher than the inlet port to prevent the clotting. And not only that, the another technique by which you can prevent clotting is using the pre-dilution. When the replacement fluid is used as a pre-filter technique, it can prevent the clotting because by giving the pre-filter replacement fluid, you are diluting the blood, reducing the viscosity, thereby preventing the clotting. So that's all. Thank you. Hope all of you have enjoyed this session. Have a good day.